Hello everyone, welcome to my video channel. Today I am going to talk about growth plate injury, part 2 of growth plate and growth plate injury topic. In this part 2 video, I will cover regarding the Salter-Harris fracture and its classification, the mnemonic Salter itself, SALTER. The S stands for split through the physeal region. A stands for the above the growth plate fracture or at the metaphyseal region. The L stands for lower, whereby the fracture occurs through the epiphysis. T stands for through the epiphyseal and metaphyseal region. And R stands for crush, whereby there is a crush or compression fracture of the growth plate. I will give an example of Salter-Harris fracture, rank and ordain additions to the Salter-Harris classification, management of the Salter-Harris fracture, and other additional viva questions, including the complication of Salter-Harris fracture and prognosis affecting the complication. Before we start, there is a disclaimer, and the disclaimer is the same in all my videos. Thank you. Now let's begin. Salter-Harris fracture or physeal fracture refers to a fracture through a growth plate, also known as physis, specifically applied to the bone fracture that affect the children. The classification system used to grade the fracture according to the involvement of the physis, metaphysis, and epiphysis. This classification system is important in terms of prognosis and treatment. This classification also facilitates communication between the healthcare providers. Most of the Salter-Harris injuries occur through the time of a child's growth spurt when the physis are the weakest. Active children are the most likely to encounter injuries involving the growth plate, as the ligaments and joint capsules surrounding the growth plate tend to be much stronger and more stable. In general, the upper extremity injuries are more common than the lower extremity injuries. Of the 5 most common Salter-Harris fracture types, Type 2 is the most common, around 75%, followed by Type 3, around 10%, Type 4, around 10%, Type 1 around 5%, and lastly Type 5, which is the very rare. Salter-Harris fracture include a classification system that allows the providers to risk stratify the injuries. Ranging from 1 to 5, the lower numbers are less severe and have less risk of growth abnormalities. I included a normal end of a bone by this illustration. For Salter-Harris type 1, starting with the S that stands for split. This is when the fracture line extends to the physis or within the growth plate, or a complete physeal fracture with or without fracture displacement. Be aware that a normal radiograph cannot exclude a physeal injury in a symptomatic pediatric patient. A radiograph may be normal. Salter-Harris type 2 fracture, whereby the A stands for the above the growth plate fracture. The physeal fracture goes through the metaphysis. In Salter-Harris type 3, starting with the L that stands for lower fracture of the growth plate, this is an intra-articular fracture extending from the physis into the epiphysis. If the fracture extends the complete length of the physis, this type of fracture may form a 2 epiphyseal segment. Since the epiphysis is involved, damage to the articular cartilage may occur. For Salter-Harris type 4, the T stands for through or transverse fracture. This is also an intra-articular fracture in which the fracture passes through the epiphysis, physis, and metaphysis. As this fracture involves the epiphysis, the articular cartilage may be damaged. In Soter-Harris type 5, the R represent crush or ram or ruin of the groove plate. This fracture type is due to a crush or compression fracture of the groove plate. The example of Soter-Harris fracture: in type 1, the slip through the epiphysis. Example is slip capital femoral epiphysis SCFE. In Soter-Harris type 2, where the above of the groove plate is involved, the metaphyseal region, when the small corner of metaphysis is visible, this is known as a corner signs or Thurston-Holland fragment. The picture on the right side shows the X-ray findings of a patient who has a left slip capital femoral epiphysis SCFE. For Soter-Harris type 3 that involve the lower physeal region, the epiphysis, the example is tilak fracture of the ankle, which is a fracture of the anterolateral aspect of the groove plate and epiphysis. For Soter-Harris type 4, the fracture that goes through the groove plate, example is triplane fracture of the ankle joint. The triplane fracture has three components: A. Vertical component through the epiphysis, B. Horizontal component through the groove plate, C. Oblique component through the metaphysis. And finally, for Soter-Harris type 5, where it is crushed groove plate, which is rare and has the worst prognosis. In exam, you can be asked in viva regarding is there any other classification of groove plate injury that you know of. Pause a bit. There is. Rank and Odgen addition to Soter-Harris classification. From 6 to 9 edition, I will describe based on the illustration. For type 6, there is trauma to the perichondrium with tethering of the groove plate. This will lead to peripheral breach. Just follow the blue arrow to see the defect in the illustration. For type 7, there is a trauma to the epiphysis or epiphyseal plate. Patient will have a chondral or osteochondral fracture. You can see it based on the dotted circle as illustrated. As for type 8, there will be an isolated injury to the metaphysis with a potential injury related to endochondral ossification. I do hope that you will be able to understand based on the illustration provided. And finally, type 9, whereby there is an avulsion injury to the periosteum that may interfere with membranous growth, as illustrated and emphasized in the dotted circle. Next, we are going to cover regarding the management of the Soter-Harris fracture. In Soter-Harris type 1 and type 2, most of the fracture are usually treated in close manipulation and immobilization, example by using a cast. In type 2, CMR, close manual reduction, is preferably to be done in OT, operation theatre. The decision for open reduction and wire, especially for distal and radius fracture, depends on the imaging during intraoperatively, whereby if the angulation is not acceptable by close reduction, with an attempt not more than 2 times, we need to proceed to open reduction and stabilization with K-wire. In Soter-Harris type 3 and type 4 fracture, this fracture requires an open reduction and internal fixation due to the intra-articular in nature, and it is often displaced. I am going to say a controversial statement. Internal fixation can be used, example plate. if the patient is estimated to grow is less than 2 years. But again, the plate usage depends. This is usually varies between each surgeon and center. We will follow up patient at 3 to 6 months with X-ray matching limb, preferably with an interval for at least 2 years. What are the complications of Soter-Harris fracture? The complications include post-traumatic arthritis, especially in type 3 fracture, asymmetrical bone growth or deformity, especially in type 4 fracture, growth arrest or growth retardation, especially in type 5 fracture. There will be an altered joint mechanics and functional impairment of the affected limb or joint. What are the prognosis of Soter-Harris fracture? Most of the growth plate injuries heal without complication. Only small percentage still develop growth arrest and late angulation, around 2%. Factors affecting the prognosis are or include A. Severity of the initial trauma. B. Age of the patient. Younger patients have more time to grow and the deformity will be greater. C. The type of Soter-Harris fracture. Type 1 and Type 2 rarely have growth problems, while Type 3 and Type 4 have the worst prognosis. It is important to warn the parents of this possibility, and we can also mention that although angulation and leg length discrepancy are problems, they can be corrected by osteotomy of epiphyseal disease or limb lengthening procedure later. And lastly, D. Growth plate affected will have an impact in the prognosis of Soter-Harris fracture. If there is a growth plate disturbance, especially at the knee and ankle, it will have the worst prognosis. Among the questions that will be asked in viva is how you differentiate type 1 and type 5 Soter-Harris fracture. Type 5 are diagnosed retrospectively. In type 1 Soter-Harris fracture, it is a split fracture. The diagnosis is based on clinical suspicion because sometimes usually the radiograph might be normal. There will be mild to moderate soft tissue swelling that will be noted, and furthermore, the complication of the growth arrest is minimal. Compared to type 5, a crush pattern whereby the growth plate will become damaged and the patient will have significant complication, example, especially in a growth arrest. Another question during viva is how to reduce damage to the growth plate during K-wire insertion. Number 1. Trial of CMR, closed manual reduction, is less than 2 times. Number 2. Gentle manipulation should be advocated. Number 3. Smooth, narrow K-wire usage, non-threaded K-wire is preferred. Number 4. The K-wire size should be less than 2.0 mm. Number 5. Reduce or avoid multiple attempts of K-wire insertion, preferably single attempt only. Number 6. K-wire inserted by hand or using an oscillating drill. If standard drill is used, it must run as slowly as possible to avoid a thermal effect. Additionally, we can irrigate the K-wire during drilling with a cool irrigation fluid. Okay, that's all for today. I hope you have learned something from this video. Good luck and all the best in your future exam. Thank you. See you next time. Bye.